and I'll be moderating our first session. So this is all about sharing research that's happening here at the University of Minnesota and bridging it with community action. So here's the plan. We'll hear 3 talks. They'll each be around about 10 minutes long, and then we'll have about 20 minutes for a discussion and Q&A session with our speakers. I'll be charged with trying to keep us on time today, so I'll try to do a good job of that. For our first speaker today, we'll hear from Dr. April Wilhelm and Abdillahi Kahin on their community engaged project using education to reduce hookah or shisha use in the Somali community. Following that, we'll hear from Dr. Rebekah Nagler on how to navigate health communication and messaging today. Pretty big topic that's never been more important. And finally, Dr. Silvia Balbo will be talking about the science of alcohol and cancer risk and what it means for everyday choices. So we're really looking forward to all these speakers. Before each talk, I'll invite the speakers to briefly introduce themselves, and their full bios are in the speaker documents that you can grab at the registration table. So if you're curious to learn more about them, there's more information there. As you're listening today, if something sparks a question, please jot it down, hold on to that thought so we can talk about it together at the Q&A session. So we're going to hold the questions for that 20 minutes at the end. So with that, let's begin. And I'd like to welcome our first presenters, Dr. April Wilhelm and Abdillahi Kahin, to come up and share their work.
Good morning, and thank you, Rebekah Pratt. So our project, thank you. Our project is called Shisha Smoke-Free Homes. It's a community-engaged research to reduce shisha smoke exposure in the Somali homes. So, oh yeah, I forgot to introduce myself. Thank you. Good morning. My name is Abdillahi Kahin. I am a program manager at WellShare, and basically this is a collaborative project between the university and our organization, WellShare International. Yeah, I was so focused on 5 minutes, and then thank you. And then
Yeah, and good morning, everybody. I'm April Wilhelm. I'm a family medicine physician and a assistant professor in the Department of Family Medicine and Community Health here at the university. All right.
So our project on shisha, and so I'm going to talk about first what shisha is. So yeah, as you can see the image, that is basically what shisha is. And it has at least 3 different components. The bottom section, which is kind of blue, at least in my view here, is the bottle where the water is held. And the middle section is what contains the pipe that is used to smoke the shisha. And the top section is where the hookah itself, the tobacco itself is put, and then right on top of it is where the charcoal is put. So that is what is used to smoke shisha. And that is what, makes it possible to combust and smoke shisha through that. And the thing about shisha is, and what makes it interesting for people, at least a lot of young people, is that it's flavored. And there are so many different products that has different flavors that are tailored for people, especially young people, to entice them. It's fruit, banana, strawberry, all so many different kinds of flavorings, and that's what they actually call them. Strawberry, a banana, and that tricks you that you're smoking a fruit, which itself is dangerous too, Smoking something is dangerous. And so that is what makes it interesting. And you're not smoking a fruit, you're smoking a tobacco product, which is dangerous. It's known to contain similar amounts of chemicals, just like cigarettes. There are more than 4,800 different chemicals, in which 69 of them are known to cause cancer to humans. And another misconception that people have about shisha is that because it contains water at the bottom of it, that water is filtering the dangers, the chemicals, the things that would cause things that can impact your health. So that is another misconception, along with it's a fruit. You're filtering it, so a clean smoke is going to your body, which is not true. And another one is that because shisha is smoked oftentimes it's very hard to smoke outside. So it's smoked in the house, in the home, where there is a longer session. So once you light it, it's a social thing where people come together and smoke together. So that also, adds to the problems, to the risks, to the health that shisha causes to the smoker. And also along to the smoker, the people in the home is also impacted. And as I said, just like cigarettes, there are all kinds of chemicals that can cause different kinds of cancers that are known the cigarettes to cause. So lung cancer, bladder, oral, and heart disease, and so many other health issues that they cause. And another danger about smoking shisha is it's in the house. And the house and home is where the kids spend most of their time when they are in the home. So when it's smoked in the home, they're getting exposed to that. And oh yeah, one more thing. So I'm gonna say quickly, when I was a kid, I was asked by a family member to, I was like 5 or 6, go light a cigarette for me. And ever since so I grew up, I thought, that is, when you grow up, that's what you do, that's what you smoke, it's a normal thing. And the same is true when when kids are exposed to their adults that they trust in the home smoking shisha, it makes them believe that that's normal, that's what people do. And, they are more likely to start smoking themselves. So, yeah. Shisha is smoked by a lot of different communities. And among them is my community, the Somali community. Historically, cigarettes were more widespread, more used in our community, but more and more people started to use shisha in the last, I would say, 2 decades. It became even more widespread in the last 10, 15 years. It, is now regarded, unfortunately, mistakenly, that, it's part of our culture. It's what we do. It's, what we socialize over. Research that was done by a team from the university found that 1 in 3 reported that they use cigarettes, and 1 in 3 reported that they use or smoked shisha daily. And that was a while back. And so more research sees that it's more common now. And, as a community member, we also see that it's more normalized, more used, and spoken about it more openly. So this research is being done by a collaborative team from the university, from Wilshire International, which the team from Wilshire is the team on the top section. Myself, Abdillahi, and I am the program manager for this collaborative effort research, and 2 community health workers, Halimo and Abdurrahman. And now I will give it over.
Yeah, and at the university side, we really wanted to partner with Wilshire and Abdillahi on this project because we really wanted to better understand the parent perspective on shisha use in their home. So we brought our team listed here in collaboration with Asma Isa and Itoro Yuat are the graduate students and recent graduates on the project. And then we are also working in collaboration with Irina Stepanoff, whose lab is in this building, and she does a lot of environmental exposure research in the tobacco world. And then Christy Fortis has helped us with some of our data analysis. But let's dig into what we've been doing to better understand this issue. So in the fall of 2024, we started conducting focus groups and interviews with Somali parents led by the WellShare team to really better understand the perception of this issue in the home and what parents know about it and what are some of the things that might stand in the way or help to set up positive change in the home around this issue. And then we've been taking that information to develop and pilot test community health worker-led intervention currently with 15 families. Here's a rough outline of who we spoke with. We spoke with a total of 40 parents and 10 key informants from the community, so 50 people. The mean age of the parents was about 35, and you can see some of the other characteristics, about 50-50 split in terms of gender. Most were born abroad, but had lived here for more than 10 years. And about 40% of our sample had previous experience with tobacco use, which was helpful to guide our understanding of the issue. In terms of the results, we have many, but I wanted to highlight just a few things that have really shaped the program that we've developed. So the first is that there are some serious knowledge gaps when it comes to really understanding the risks of shisha. There's this incorrect belief that it's not a tobacco product at all, and that it's much safer to use than other combustible products like cigarettes. And that really impairs like accurate decision-making when it comes to what people are bringing and using in their homes. And there's an even more limited understanding of the risks of secondhand and third-hand smoke exposure for children and other family members in the home. The second big takeaway is that even though it's become a more accepted behavior, this is very much a stigmatized thing for many people. And so when something is stigmatized, that drives it into hiding, and it makes it a shameful thing that people don't really want to open up about. And that makes it a much harder issue then to address if it's not out in the open and something that people are talking about. And then the third major thing that we've learned that's shaped our program in response is that as any parent, right, concern for the child's health really drives a behavior change. And that's true in this community as well. So learning about how this affects children can really motivate many parents to quit. And then related to that, we asked a lot of questions about the best people to share this information with. And it's people who have relatable experiences, who have that shared cultural and linguistic background, and who can foster a sense of trust and safety for parents who are putting themselves in a vulnerable position if they're talking about this issue at all. And with that, we've developed this new program, which is called Shisha Smoke-Free Homes, Clean Air, Better Future. And we developed the program earlier this year, and we're currently testing it. It builds off an existing program that was historically developed down in Georgia at Emory. That was a mailed out program through identifying people who have smoke in the home and just sending them mailed information. And we didn't think that that would work well in this situation. And we really wanted to build on some of the principles of behavior change. So we instead developed a program that's really focused on the community health worker coming in and bringing knowledge and steps to actually guide behavior change that's really focused around this 5-step guide, number 1 up here at the top. It's a conversation guide that also has images that the participant who's talking with our community health worker can see the pictures that go along with the content that we're describing. And it's really focused on raising awareness of the risks of shisha and what parents can do to reduce smoke exposure related to shisha in the home. And then we leave behind a sign, a pledge, and all of these were developed. They're in the English version here, but they're all in Somali as well. And then a handout and also resources to help quit in case people are ready to make that change. And that's where we'll wind down today. We're currently testing this. So we've recruited 14 to 15 families and are currently doing our home visit. So we've almost completed the first round where we go in and have the initial conversation and leave the materials. And then 8 weeks later, our team is going back to check and see how things are going. Where did the snags come up? How can we help move this forward? And what are we learning through the process of how this program works? Because the goal of this pilot project is really to build a more a stronger, more robust program that can really help address this issue. And with that, I will wind down and thank you for your time. If you have any questions, we'd love to hear them in the Q&A. Thanks, everybody.
Thank you so much, April and Abdillahi. It's such a good example of partnering with the community to learn what does this mean for you and how can we make a difference. So thank you for sharing that. And next I'd like to welcome Dr. Rebekah Nagler, and we're going to hear a little bit about how health messages we see in the news, social media, maybe coming over your WhatsApp, shape conversations we have and how we understand the choices we make. Please welcome Rebekah Nagler.
Thank you, Rebecca. It's so exciting for me to have someone who has my exact name spelled exactly the same way as I do, introducing me. This never happens. I'm so glad to be here. You might be wondering why there's a media researcher at a cancer conference. And I would suggest to you it's because you probably spend a lot more time with media than you do with your doctor. And so when you think about where you get health information, where it comes from, how you make sense of it, sometimes it's conversations you have with a provider, if you have a provider, right? A medical home. Sometimes it's with family and friends. And a lot of times though, it is with media, right? And that could be digital media, that could be more traditional forms. And so as a health communication researcher, what I study is the impact that media exposure has on all of us, and especially around the health decisions we make. I'll talk to you a little bit about the particular research that my team's been doing around one particular flavor of this information environment, and that is conflicting science and how it impacts us. But I can speak more broadly in the Q&A to other questions you might have about navigating this space. I do want to acknowledge briefly that this is not just my work. This is a team that's been doing this, interdisciplinary team, drawing on funding from a number of different sources for quite a few years now. And when I think too hard about it, I realize how old I'm getting to be. So I won't date how long I've been doing this. What we've seen post-COVID is a pretty toxic information environment when it comes to health, right? There is just a lot to navigate. And if you've spent any time paying attention, even just in the 2025 context, you'll know that this is a hard moment to be communicating about health. And the three phenomena that I have up here are just a couple of them, but I think they're some of the big ones. So I want to briefly define them and kind of differentiate them for you. The first is misinformation. And we just kind of heard a version of that, right? The idea that people might have preconceptions about what shisha is and what its harms are, right? Misinformation is false information, right? Inaccurate information based on the best available science. And it's not an indictment, right? There are things that we believe that are just not true sometimes, and that doesn't make you a bad person, but it's something that if we're proliferating and sharing that information could cause harm, right? And this phenomenon predated, this has been around, misinformation dates back to biblical times, right? So it's not new, but what happens in the social media landscape is it's so easily shared, right? And we can come across it so readily. And so COVID, we really saw an exponential increase in the amount of misperceptions that people had about what caused it, how to prevent it, so forth. Politicization is the second phenomenon, and this is a really tricky one to explain quickly, but it's this idea that political cues get embedded and attached to health and science issues. And what's really tricky about that is that political actors often have motivations, right? And so then there's a point of view that's getting strategically sort of attached to what should be issues that are probably free from those kinds of perspectives, right? And when we do have political cues attached to certain issues like, say, vaccination, we might interpret that information through a particular lens based on who we are, right? Or what our own ideologies are. So it really muddies the waters from a health decision-making perspective. And that's the second thing we've seen a lot of since COVID. Again, predates it. If you think about the very title Obamacare, that's a political cue being attached to a health policy, right? So it's not that it's new with COVID. It's long been there, but it's gotten more tricky. And the last thing is conflict, which is what I've been studying for the last 15 plus years, which is basically shifting evidence, right? Or evolving science and how it seems to give rise to different recommendations, right? This idea that experts keep changing their minds about what you should be doing to stay healthy, whether it's about, nutrition, right? And so, if the Onion talks about it, if you're familiar with the Onion out of medicine, right? One of my favorite headlines from many, many years ago, eggs good for you this week, right? How many of you have seen nutrition information change over time about what you should be eating? Yeah, right? This is a pretty dominant thing. Coffee, alcohol, I know we're going to hear about alcohol, fish consumption, vitamins, like the list goes on. And we can try to unpack, there are very legitimate reasons why this can happen, but from a public information perspective, there are some real consequences that we see. So these are some headlines thinking, might come across a story one day about how red wine is going to improve heart health, right? We saw those messages for such a long time, but now, oh no, wait, it also increases the risk for breast cancer. So as you're reaching for a glass of wine at night, what do, right? How do you make sense of that information? Mammography, this is another one. We're at a cancer conference, right? The shifting guidance around mammograms has been pretty consistent over the last 30 years, right? Should women start screening at age 40, 45, 50? Different professional organizations recommend different things, and they change, right? Every year, every other year. And there's really, again, legitimate reasons why you have this conflicting guidance, but from a public information perspective, it's hard to negotiate. So what we've seen over time, where we look at effects of exposure to conflict about evidence, conflicting recommendations about nutrition, mammography, e-cigarettes, HPV vaccine, COVID, on and on that goes, what we see is that a lot of negative effects, sort of undesirable outcomes, right? So negative emotional responses in the form of frustration and distress, a lot of negative cognitive responses. My arrow is, oh, there it is. Okay, it's so hard. I'm like, I just got an eye exam, but I cannot read anything that I'm seeing up there. People get confused, right? Like, what should I be doing to stay healthy here? How do I make these decisions? Backlash, this idea of like, I'm going to stop listening and do what I want because they keep changing their minds, right? And that's not an outcome we want. Perceived credibility, right? Decreases in that, both in science and in journalists, right? I sit in a journalism school, so I think a lot about public translation of this information and how it can impact the sources we use to advance it. Decrease, lower intentions to engage in healthy behaviors that we might care about, and including, I would say, what our team has shown, this idea of carryover responses. So if you've seen if you've had more exposure to conflicting information about a range of topics, across a range of sources over time, you're much more likely to not be receptive to subsequent unrelated health messages that you're exposed to, even about behaviors for which there's consensus, right? So what I've seen in some of our experimental work with the broader US public is that if you've had like a heavy conflict diet, you're less likely to say, trust the campaign about physical activity, right? Or about fruit and vegetable consumption. And so in this way, the broader information environment can really be undermining our public health messaging more generally, which is really concerning to me. You might be asking yourself, like, well, is this everybody, or are certain groups particularly vulnerable to this kind of information? And our teams looked at that. And I would say that no one gets off scot-free. This affects all of us, right? Even if you have a really good handle on what research is, how it works, what the scientific process is, we can all still find ourselves affected by conflicting information in ways that are adverse. And it doesn't mean we shouldn't still be looking for it to see whether there are particular subgroups who are especially susceptible to this kind of information, but so far no one's getting off scot-free. So in the last couple of minutes, I'll just sort of say to you kind of how I'm thinking about addressing it, because why this conflict happens is actually because this is how science works for the most part. Thank you. So it's incremental, it's iterative, right? The work that scientists here at the Masonic Cancer Center are doing, like they might, take 2 steps forward and then 1 step back, right? An observational survey study shows one thing and a randomized controlled trial shows something else, and then they have to try to reconcile it. So there's reasons that it makes sense, but what we know is that public understanding of science remains kind of not so good, right? The national data speak to that. So what if, one thing our teams played with is like, what if we find innovative ways to talk to people about science and how it works? So we've got these are gonna be really hard to read, but I'm glad to talk more about them after. But like if I gave this analogy of like turbulence on an airplane and how the pilot turns the seatbelt sign on and off, it's not because they've changed their mind. It's because the conditions have changed, right? There's suddenly the air change and they're not flip-flopping, they're adjusting. And so using that as an analogy to explain how science also similarly works this way, right? So don't start distrusting it. Just understand that that's a feature, not a bug, right? If we do that, for example, in the face of people's information exposure to all those kinds of health topics we talked about, would it give people the ability to withstand those negative sort of experiences when they're exposed to shifting science? Would it strengthen their perceptions of science and why it matters, make them more receptive to health information, recommendations coming down the pike? Would it even increase support for public health authority, which we desperately need right now, if we are to kind of ensure a cancer prevention oriented future? A lot of my work has been with the Minnesota Department of Health, trying to think about, could we embed some of these messages about science in campaigns that they're doing? And then again, with journalists, can journalists play a role in better communicating about the scientific process? The last thing I'll say is, we're in a particular moment where, to come back to that original triangle I showed you, that trifecta of politicization, misinformation, and conflicting information, where now we have conflicting guidance that's not just among health experts, but it's between health experts and politicians. And we're seeing this with vaccination. We're going to have to figure out how to navigate it. My advice, if you want a sort of TLDR version, is if you have a trusted source of information in your community, if you have a trusted healthcare provider, that continues to be a really good place to go. Read widely, right? Don't trust one news source. Read across the spectrum. Try to get health recommendations from a range of different sources where there's some value to be had. And I would, my own bias would be, of course, that the Masonic Cancer Center can be a really good source of information about guidance if you're not sure. But if you find yourself, swaying in the wind with conflicting information, it's not just you. This is the information environment, and we all have to find a way to think to better navigate it. So I look forward to your questions, and thank you for your attention.
Thank you so much. I really love that analogy about turbulence. So last time I was on a plane, they called it rough air. What does that mean? Anyway, but what an interesting point, that navigating misinformation is a little bit about understanding how information is always changing as well. Which brings us very nicely to our next speaker, Dr. Silvia Balbo, talking about the things we're learning about the link between alcohol and cancer, which is somewhat emerging. So thank you so much for joining us. Please join me in welcoming Dr. Silvia Balbo.
Thank you, Rebekah. It's great to see such a full room of people interested in learning more about what we do here at the Cancer Center. I'm Silvia Balbo. I am the co-leader of the Carcinogenesis and Chemoprevention program here at the Cancer Center. My lab is right there, just upstairs. And it's really exciting to be following two great lectures, because I think that the alkaline cancer story sort of highlights some of the things that are some of the challenges that we have in addressing some of these connections, and then really making sure that people understand what they mean and how we can use the work that we do here at the Cancer Center to address some of the information gaps that really are limiting our ability to be very effective in giving guidelines. So I think that, just in addition to what you've just heard, one of the problems that we have is that sometimes we don't have all the information. And so we're trying to figure out things through associations, through what we see from our experiments, but we know that maybe our experiments are done on a very specific population and they may not be adaptable to other populations. So we're missing that information that helps us be more prescriptive, more precise. So I'm going to guide you through the alkaline cancer story and hopefully give you a good example of this. How many people here in the room know or heard about the connection between alkaline and cancer? Raise hands. Good. So this is something that probably is going to give most of the audience some new information that they can take home. We actually have known that there is a connection between alkaline and cancer since 1988. So it's been a long time since the International Agency for Research on Cancer has classified alcohol as a carcinogen. It is estimated that around 5 to 10% of all cancers in the Western countries are related or attributable to alcohol consumption. And the interesting thing is that it really doesn't seem to be related to the type of alcohol that we drink, as either beer or liquor or the glass of red wine. All of these different drinks have an association. And so it really comes down to the ethanol, the alcohol that is in all of these different beverages. Just to bring it back to the American and to the US situation, it is estimated that over 20,000 people die each year from alcohol-related cancer. So it's a major thing. But as we've seen in this room, not many people know about this connection, right? So just as we were still toasting the New Year's Eve with our champagne glasses in our hands, the Surgeon General came out with this report reminding people that there is this connection, that we've seen a connection between alcohol consumption and cancer. And the reason for this was exactly that. Compared to other risk factors such as tobacco, asbestos, obesity, the idea and the understanding and the knowledge of that connection with alcohol and cancer was still very low in the American population. So only around 50% of people know about this connection. And I think that the little test that we did here in the room sort of reveals that there's still a lot that we need to do to raise this awareness. So alcohol is related to a number of different cancers. Cancer of the mouth, the throat, the voice box. So we call it head and neck cancer, with the esophagus, breast, liver, and colorectal that have been added to that list as well. The Surgeon General report highlighted how, despite the fact that in the past we have sort of always associated this connection, for those of us who knew about it, to people who were really heavy drinkers or even had history of alcohol abuse. But in reality, the science that we have collected more recently is really showing that that risk for these cancers is increasing when we are also drinking lower amounts of alcohol. And this is true for both men and women. And specifically, when we're looking at breast cancer and the connection between alcohol and breast cancer, we have a significant increase in the risk already for less than 1 drink a day. So that shifts the attention to the fact that also lower amounts of consumption can increase our risk. Now, despite the fact that we have this evidence and we know about this, the problem really relates to the fact that we still don't know, and we still don't have the ability to understand who among all the people that are exposed are those who are going to develop cancer. And that is really the problem here. We know that tobacco is leading to lung cancer, right? But we also know that not all people who are smoking ultimately will develop lung cancer. We know that people are drinking maybe at higher risk for some of these cancers, but not everybody will develop those cancers. So how can we make sure that we make this information more real and more connected to really what is the precision that we need in order to give better guidelines? And the reason why we don't know all of this is because we're still missing a clear understanding of what are the steps that are leading from alcohol consumption then to events in our bodies that are leading them to cancer. We don't know all the different steps. We don't know all the mechanisms. And this is really the focus of all the work that we're doing in the carcinogenesis and chemoprevention program, looking at various exposures, really trying to tackle those questions about what are the steps so that we can understand when they're happening and who they're happening and how we can prevent them from happening in the first place. In particular, when talking about alcohol, I mentioned that there are different sites that can be affected. And because there are different sites, we also know that there are different mechanisms that potentially could be playing a role. And so this adds complexity to this. We know that there is some evidence that is showing that alcohol is broken down to acetaldehyde, which is a molecule that is genotoxic, that is affecting our DNA. And this seems to be particularly important for cancers of the mouth and the esophagus. We know also that alcohol is inducing oxidative stress, reactive oxygen species leading to protein and DNA damage, lipid damage. This seems to be particularly important for liver cancer. We know also that alcohol can affect the balances of hormones. And so that seems to be the mechanism that is relevant when we're considering the connection with breast cancer. And then finally, alcohol is a great solvent. And so if we are combining alcohol with something else, with other carcinogens, then we may have an increase in absorption. And this is true for people who are smoking and drinking. Their risk for head and neck cancer is skyrocket higher. So higher than just people for those who are just smoking or drinking. So really showing that synergy that probably comes from this solvent ability. So here upstairs in my lab, we're really focusing on the mechanism that is looking at acetaldehyde and the role of head and neck cancer. And the reason we're doing this is because in people from East Asia, from areas in the world like Japan, China, Taiwan, we know that there is a large number of people that are carrying a genetic variant that is leading to a decreased detoxification of alcohol. So they're less efficient. So you probably know of people that when they drink, they flush, they have a reaction. If they keep on drinking, they are much higher risk for head and neck cancer. And interestingly, they're not at higher risk for liver cancer or breast cancer, but it's really focusing on this mechanism being relevant for what happens in the oral cavity. And so that is what we're doing here at the Cancer Center, is really try to understand if there are ways to keep digging further into these mechanism steps and understand how this mechanism is leading to cancer of the oral cavity. Now, this says, just going back to, aside from the work that we're doing, the fact is that we still are just relying on recommendations that are very generic. And this ties back into what we started with. The lack of information leads to the fact that despite knowing that there is this connection, despite knowing that there are some mechanisms that we should look at, the final guidelines are just that women should drink less than one or less drinks a day, and men should drink probably a top of or a max of 2 drinks or less a day. But that's it. There is no variation in looking at people that maybe have a different genetic background or that have maybe other different risk factors. The problem also comes with the fact that all the studies that we're doing are based on one standard drink. But what is that standard drink? And here you have sort of a picture that shows that you have a can of a beer that is 5% alcohol. You may have a glass of wine, which is a small glass of wine of about 12%, but a lot of the wine that we drink is 14% alcohol. And then you have a 40% at the very end spirit drink, which is, again, a very low dose. So the typical 1 drink a day recommendation that we have, it's quite low, and it can vary depending on what you're drinking. So there is a lot of difficulty in being precise in providing that information. So for now, what can we say? We say that in general, drinking in moderation is a good idea. It's better, and it's better for you. What does that mean? It means that if you are drinking more drinks than 1 or 2 drinks a day, you should probably try to reduce the numbers or potentially reduce the volume, make those drinks a little smaller. If you're drinking every day, maybe try to alternate with days in which you don't drink alcohol or you drink alcohol-free alternatives. Drink a lot of water while you're consuming alcohol, so that dilutes the amount of ethanol that you are ingesting, and drink with food. And so don't drink alone, but make sure that you have something in your plate and that you're mixing the alcohol with your meals, so that again you reduce the absorption. And then consider alcohol-free alternatives. So again, pretty generic recommendations. We're really trying to work to provide better ways to be more prescriptive and be more effective. Ultimately, the scope of the work that we do is that instead of just giving general signs, generic signs, when you're driving, you have a slow down. It's like, yeah, okay, I can slow down. But it's different if we say, well, slow down because children are crossing. Well, then you start getting a little bit more alert about little humans moving around, right? Or the road is rough. Then you are thinking about the fact that you may damage your car. Or there are dangerous curves, and then you hold on tighter to your steering wheel to avoid flying off the road. So being able to provide more information attached to these prescriptions or to these guidelines really can be more effective. And so that's really the focus in all the work that we're doing here. And so with this, I'm looking forward to questions later on. Thank you.
Thank you so much. That was very, very interesting. We're now going to open the floor for questions. So what I'm going to ask is that if you have a question, to raise your hand, and we'll have somebody bring a microphone to you. That's so our folks that are online can also hear the question. The other thing that helps with our questions and answers today is we have translators in the room. And so if we talk slowly and clearly, it helps them also with doing their translating so everybody can catch answers. So that's a good reminder for me too, because I tend to talk a little quickly. So just to speak slowly and clearly will help. Also, if you're online, feel free to drop your questions in the chat or using the Q&A feature, and we're keeping a little eye out for those questions too. So I'll open it up for our first question. Wonderful, we have a question here. So we're gonna go number 1 and then number 2. Microphone's coming. Thank you. That's the first question. Is the microphone on? I'm not sure. Hold on. Nope. I'll also bring this one over. Try now.
Hello.
There you go. Perfect.
Okay.
Thank you. The magic happened. Please go ahead.
Would you like me to stand or?
It's up to you. Whatever you're comfortable with. Yeah.
I'll stand. My question is really specific.
Okay.
I had to have a biopsy, a breast biopsy, because they saw something. And I did do that, and it came back negative. They actually rescreened me to find out that it was not cancer. The next year I did a mammogram as well, and it was clear, but this is the 3rd year now, and I was told I don't need to have a mammogram. Why would I not have to have a mammogram now if there was a possibility 2 years ago that I may have had cancer?
Okay, thank you for your question. I'm going to ask if anyone on the panel wants to talk to that, but we also can make sure that there's somebody here today who can answer that question for you. Does anyone here want to have a go at that, or shall we pass on to finding one of our other medical experts today? Thank you, April.
I think it's hard to give a clear answer without knowing a little bit more specifics. As a family medicine doctor, I hear these kinds of questions all the time, and I think it's really complicated. The screening decisions are individualized for your specific situation. So I definitely want you to get the information you're asking. And I think I would be happy to have more of a conversation with you, or I know there's another handful of physicians in the room who would be so happy to kind of walk through that with you today. Because it's a very complicated thing to navigate for a lot of people.
And I was wondering if it was just the health plan that I had. So.
Okay, we had one question here, and then I will come to you. Oh, you have a microphone already. Perfect.
Hi, I actually have 2 questions, one for Abdillahi and Dr. April, sorry, and one for Dr. Nagler. So in your presentation, Abdillahi and Dr. April, you said you used a qualitative study to design your program. Do you have any interest or plans to do a quantitative study so the results are more usable in policymaking?
Yeah, we used qualitative research to guide the adaptation of the program, and we're currently doing a pilot testing where we're getting survey information. We probably won't have quantitative information that's very translatable for policy at this stage, because we're just trying to figure out if the program works. But we're hoping that our research now will lead to a bigger number of participants and hopefully have some more information. And I don't know, if research is slow, 5 to 10 years, probably. Thank you.
And then Dr. Nagler, my question for you comes from my own coursework in my Master's of Public Health program. I was reading a study this week that looked at the difference between traditional media and social media accuracy, noting that traditional media through TV, news websites, magazines tends to be more accurate as opposed to social media. With your experience and being more current, do you have an opinion on whether or not that is the case?
For the traditional media, were you specifically thinking about news or entertainment, like other forms of content that would also appear on those platforms?
Specifically news, because
Yeah.
that's where the older population, 30 and above, like myself, tend to get their news.
Yeah, it's a great question. And I spent a lot of time teaching undergrads here at the U, and we talk about these very issues of sort of the not all information is created equal and how does it get produced, especially around health, but not only health. I think that's right. So the research that I have seen suggests that, for example, I can give you the case of like globally, countries whose media ecosystems are more dominated by social media compared to traditional tend to have lower levels of public trust. There's all sorts of sort of knowledge deficits that we see. And so there's reason to be mindful about sort of the prevalence of social media use and what it does for sort of our trusted institutions and our public, sort of political learning and various things. The reason I think that could be the case is because news production, journalistic norms and values, historically, there are standards of accuracy. There's a code of ethics that goes into producing knowledge, and social media actors, whoever that could be, right? Content creators, we're all content creators, right? We can do whatever we want. We're not held to any sort of standard, right? So part of it, I think, is that, and it's not to say that journalists don't make mistakes, but whenever they do, you'll notice they have a retraction or a correction that they advance, and they take their sourcing really seriously. And again, it's not to say that there's not some problems that need to be sort of institutionally addressed, but I think that's probably why.
Thank you. Then we're going to come here, and then the next question will be yourself. So number one, number two. No, number one, number two, either way around.
What's up, everyone? I have a comment and a question in regards to breast cancer screening. I think you all historically know of the prevalence of the medical community around African-American women. So just let that sink into you. And then also the insurance companies, yes. So I'm a breast cancer advocate, and we do have a table. And so I was told that as long as you have breasts, you need a breast exam. Okay, that's just a sidebar. But in regards to alcohol, I got a chuckle when it said about flush. Highly melanated people do not flush. So how do you respond to that?
Yes, so it's a very good question. The flushing experience that I showed was something that is very evident in these Eastern Asian communities where genetically they have been screened, and we have seen that 30% of people that are from Eastern Asia carry this particular genetic background. This is not true for people from other areas in the world and ethnicities. That said, though, it could still be possible. The flushing is just one major event, but the other thing would be that you still feel warm in the cheeks and you have nausea, you have headaches. So it's just that the flushing is something that is very known and clear in those communities where this genetic background is so high, and so it's very frequent. But that is not to say that is not something that you can see or detect with other symptoms that are associated with it in other people as well. And some people that is very rare, but people from other communities may experience that too, and it's something that comes with those symptoms, not just the redness in the face. Mm-hmm.
Great question. Excellent. So we're going to come to here. Who's next after that? And then you'll be next. So number one, number two, please go ahead.
Hi. First, thank you. That was amazing information. I'm Vanessa, both breast cancer survivor and advocate. So my first question, I have a couple of questions. My field question is for Dr. Balbo. I myself know the correlation between alcohol and cancer, but I'm surprised that even my own oncologist never talked to me about it. How we can close that gap between, or doctors conversation with us one-on-one and us. Me, I know that information because I'm hearing everything that I can squeeze information from, but a lot of people are not in that way. So how we can close that gap?
Right, this one, yes. Okay, so yes, I hear you and I agree with you. The fact, and that is the reason why I show that we've known this for a long time, but there's not been much in terms of really sharing the information and making sure that people understand what it means and what is, what are the implications. And that exactly is the reason why the Surgeon General, before leaving his role, and he put out the report because it was clear from taking a poll of the American population that is still something that people don't know and don't talk about. And even when we know that there is a higher risk for people that are of Eastern Asian descent, we still don't talk about the fact that it could be specifically a risk for them. And so with that, that's the reason why I come to talk to these events. And that's the reason why the WHO and IARC, so the International Agency for Research on Cancer, has started pushing out a lot of news and a lot of information about this, because clearly the science was silenced in a way that it didn't really translate to, what people know. Obviously, is also something that is bad news, right? When I go back home, and so I forgot to introduce myself because I wanted to talk about the science and not about myself, but I'm from Italy, and from a region in Italy where people are producing wine. When I talk about what I do, I don't really cheer up the, the audience much. So there is that too, the reluctance of wanting to hear the information. And then the fact that there have been studies that have shown that a glass of red wine is good for you. But those studies were studies that were small, that have not been reproduced. And once we went back to see how they were conducted, they were not studies that were robust and they were not reproduced. But that news was out there. It's cool. I can have this glass of red wine because it's good for me. And I'm going to stick to that news because I like that news and I want that to be real, right? So there is that too, where it's not just the lack of information, but also having to counteract the effects of information that has been general knowledge that was positive. I can tell you that there are books about diet and cancer that I refer to because people have told me, oh, I've read this book. It's fantastic. It's from the medical doctor that has looked at all the different things that can help you. Well, when it comes to the chapter of wine, it really, or alcohol, it doesn't, it sort of skips it. It's just say, yeah, there's some research, but we're going to focus on, avocados and kale. Perfect. But you're missing one piece of that whole puzzle. So absolutely true. And that's where I think we need a lot of work in that particular area still.
That's a great question. It shows how much work we still have to do to educate everyone.
Grazie for that. In that same note, and what is there in the media of it, and what is there that we can spread as an individual, because our content creators we are. How, for example, people like me, I am a breast cancer survivor and advocate, and my social media is all about information like this. How I can myself increase my credibility there when I share information like that. It is a strong link between alcohol and cancer. How I can increase that in my platform?
These are great questions.
Well, maybe citing Dr. Balbo for one thing. No, I mean, if you can bring research and translate it, right? That's one of the real tricks, like what we've seen with these, pediatricians, for example, who have taken to TikTok to translate vaccination information for parents who are struggling, right? That it can be short and pithy, but you still have to bring the expertise. You still have to bring the credibility, right? So I think if you can source it, but keep it, in layperson language and keep it, pithy, maybe that's one way. I will just say one other thing that Silvia didn't mention that I think is a major important player in the competitive communication environment, which is lobbying, right? There is a very powerful alcohol lobby in the United States, not unlike the insurance companies, right? Like where you have players who have power and who are trying to shape a narrative and maybe depress language that would otherwise bubble up.
I think my kids would pay me to stay off TikTok, by the way. So we've got one here, and then number 2 here, and then number 3 over the back. We'll keep trying. So please go ahead. 1, 2, 3 over the back. And I saw you there as well. Yeah.
Thank you so much for the great presentation. I work with the county, Hennepin County, as the engagement specialist for the AIPI community. And it's hard because the people that we serve are marginalized, and disparity is so high, especially within the Hmong community. So my question for Dr. April and Abdillahi. So it's really hard to reach out. So my question to you is how the pilot group, accept that, challenge, because is there any incentive? Because usually when we have issue with family, smoking, drinking, we don't want to share with others people because it's family, it's personal. So for us as engagement specialists, how can we make it a better approach and make it more friendly and make sure that also that it will be impact not only for those family, but for the whole community? Thank you.
Thank you. So I manage this project that collaborates with the University of Minnesota on this research, and our organization hires community health workers. So it's our workforce is basically the community health workers, and we work with a number of communities, including the Somali community and other East African communities. And the community health workers who work on our programs are people from the communities that they serve. So people who are known in their communities, who are respected in their communities, and who shares the same experiences that, their communities basically us. So people from that community. And so they know how to reach people, they know where to reach the community members that we're looking for. So that really helps us in recruitment, in projects and programs like this, and to also, we do a lot of education in the community. So that is where they spend their time. So same people from the community who are visiting, who are comfortable in, starting a conversation out of nowhere, talking to me, in the local mall, talking to me about tobacco use, anything. So the right people, the right community health workers. And oftentimes they have that experience, from the communities that they serve. And also they have certification, community health work certification. So, training, certification, plus the right people, leaders from that same community.
Thank you. Oh,
Well, I was just going to add on, and you asked about incentives. Yes, paying people for their time in a meaningful way is really important for us. So for our particular pilot study, we're paying people to complete each part of it. So the survey, if they were comfortable with the biospecimen saliva collection, they get paid for each one. So I think just having compensation and community connection really empowers this kind of research, and we couldn't do it without a partnership. It's important.
thank you. Just a fair warning, we're kind of heading into the zone. We're going to start running out of time for questions. I have seen you there, number 1, number 2, number 3. How about that? Did you want to go ahead and ask a question? Oh, here we go. These questions are fantastic, by the way. I'm reluctant to have us tie up soon, but please go ahead.
The question I had was that the comment was made that you have breast cancer. Well, if that's the case, why is it only women get screened, men do not? Because they're just as susceptible as getting cancer as women are, especially if they got mothers if your mother has had breast cancer at all or anything like that. You drink from that breast, your brother, your sister drink from that same breast, who's to say you don't have cancer as well, and men don't get screened when women do. I think it's unfair.
Thank you for that. Do you want to make a comment about?
Yeah, I think that it's higher incidence of breast cancer in women, but if there is a genetic underlying risk factor for breast cancer that's known about in the family, men actually are recommended to get screened as well. So we're still learning a lot about all the different causes of cancer, and when we're doing screening, we try to screen the people who are at the most risk, because it's hard to screen everyone. And so there's been targeting with some of the guidelines, but like I said before, it's really complicated and it's an individual decision with your doctor that I think is the best for that.
Yeah, and I appreciate all the statements that are really advocating for our breast cancer screening from all of you today. Okay, please go ahead.
I have the question in regards to the secondhand smoke that happens in the family setting. And as a child that may have cancer, how families are dealing with that, the guilt that might come from the parents, the fear that might come from siblings. Is that part of the next step of the research and the preventative side of things?
It's a great question.
Yeah, it's a great question. You know, I think when we're talking about prevention, it's really important to bring awareness, but not cause people to feel shame to move change. And so a lot of the messaging that we've been developing is that these are things we can actually do to help keep your family healthy, and we're here to support you. And that importance of supportive messaging is really important. We've focused more on that messaging strategy, and cancer is so complicated, it's hard to directly attribute a cause to a particular thing. If a family has a child with cancer, the last thing I'm ever going to do as a physician is try to put the blame on those people. That is not, that's not a helpful position. So our approach is prevention and really support to make a healthy change wherever the family is at. Anything else?
Thank you. And we're heading into our last question, although people may linger around a minute after we're finished if you have other burning questions you didn't get answered. So our last question here. Thank you for the comment. And I'm going to repeat a little bit of it for our online users, which was again about this difficulty of educating oncologists who may know a little bit more than perhaps you just learned today. And how do we approach that? A quick comment, Silvia?
Yeah, the comment is that, as we said earlier, we need to do a better job in translating what we know to actually the practitioners and the guidelines that we're giving. We saw that the guidelines that we have are so minimalistic and they don't go into, well, consider also other risk factors. And if someone has had breast cancer, what do they do? There is nothing about that. And so it's really where we still need to fill those gaps so that we can have a clear understanding of what all the risk factors are. And then I can say, you know, looking at your chart, looking at where you're at, you should probably stay away from alcohol, or you should really reduce. Are you having a glass of wine, red wine every day? Let's cut that down. We are not able to be that precise and that specific yet because of the fact that we don't have all that information and we are having a hard time personalizing it. And so we know that that is an additional risk factor. We know also that alcohol is interacting potentially with the drugs that you're taking if you're having a treatment. That is something that we have to keep in consideration as well. So there could be more than just the cancer risk connection with alcohol, more to alcohol itself as something that may have an impact on the general health that we can take into account. So I think that there is definitely a lot more that needs to be done to better address your question. And I totally understand and agree that we're very far from being effective in that context.
Thank you very much for that. I'm just standing here, which means I'm in trouble for my timekeeping now. Look, she's pretty scary, isn't she? So I just want to thank our speakers again. You're learning things that we are learning and sharing. And so it's wonderful to hear you interact with our speakers. It's wonderful to hear this breaking research from our speakers. And thank you for your questions. I had some backup emergency questions. You all asked better questions than I had. So I really appreciate that. So a big round of applause for the whole room.